wide. One of the other things that must happen when a radical prostatectomy happens is you do have to remove that big valve or sphincter. That now you do have to rely on the external sphincters to control your urine because the big one is gone. Of course, the sexual dysfunction because the prostate's a sexual organ, as I mentioned. But the problem that I mentioned is as you go up the ladder with aggressiveness with cancer, the higher the probability. So this gentleman said Gleason 9. Well, yeah, Gleason 9 is real high probability of this going on. Maybe you can't see it, but it's a real high phenomenon. So that, interestingly, and I have thousands of patients that I follow. It appears that the men who have radical prostatectomy and they're doing fine years later, or they don't relapse for a really long time, is because they had lower grade prostate cancers. And maybe these tentacles weren't so pronounced or prominent. So if that answers your questions about that, listen, I'm biased. I'm a radiation oncologist. This is what I do, but I did learn a long time ago the prostate didn't have a capsule, and that solved some problems for me because I had a lot to do with the pioneering of brachytherapy or seed implantation, which is where, you put these tiny little dots right into the tumor. And to this day, it remains the most precise type of radiation. Nothing else exists that's as precise as that. When I first did that, I was really jumping ship from radical prostatectomy because I didn't like it. I thought, leaving men with incontinence issues and erectile dysfunction wasn't good. But I also was finding there was a failure rate that, you think if you go through all of that, incontinence, leakage, sexual dysfunction, and again, not everyone gets it. They don't get the leakage, but they typically, well, most do. But when I found that out, I looked for other ways of treating the prostate, and I did other things that you may read about, like freezing the prostate, called cryosurgery, heating the prostate, called HIFU, and brachytherapy, seed implants. And for a while, I had the largest series in the world at this hospital in New York with prostate brachytherapy alone, no other treatments, just alone, which was great because I could get brachytherapy done in under 20 minutes. Wouldn't need a scalpel. There's no cutting. A gentleman could be here the very next day at a conference. You couldn't do that with radical prostatectomy, okay? And minimal blood spillage. I didn't know why with brachytherapy, as time was going on, I was still seeing some failure rates because I said, with surgery, the radical prostatectomy, there was a fair amount of blood being spilled, and we've already talked about that, okay? Just the biopsies alone can spread cancer. So you can imagine when you're having radical prostatectomy, that could also do it. But why was it happening with brachytherapy? And that's when I spent a lot of time in the surgical pathology lab to learn the prostate didn't have a capsule. And it was based on that I realized, oh, we need a bigger mousetrap here. We need to get these guys, we need to get the lymph nodes, since they're commonly involved by prostate cancer. I came to find if a Gleason score was even 6 in high volume, it had a fairly high probability of having lymph node dispersion. We were doing a nanoparticle test here, which was great. Long story why it's not still done, but we did it, and we worked with Harvard and University of California, San Francisco, and a university in the Netherlands, and found what I'm telling you, and that is if a person has a high volume tumor, even Gleason 6, and certainly 7s, 8s, and 9s, and 10s, they almost always have some degree of lymphatic drainage, and that's because the lymph nodes sit so close to the prostate. They're there to remove things and filter things in our bodies that are not supposed to be there, and that's what happens. And when I realized that and started treating lymph nodes, that was an absolute game changer with respect to cure. But it's another kind of radiation, and that's where we use another kind of radiation, which is called external radiation, which can be protons, neutrons, photons, electrons. There's different ways of doing that. So anyhow, yes, sir.
Difference between a Gleason score and a PSA.
So he's asking what the difference is between a Gleason score and a PSA. And so the PSA is prostate-specific antigen. It's specific to the prostate, okay? And when there's cancer, there's more being made, and the PSAs go up. Prostate cells, even benign prostate cells, do make PSA as well. It's just that when you have uncontrolled growth of a cell, then it's going to make more. Okay, so we were very fortunate. It was back in 1989. The first doctor came up with PSA, and he was in Michigan, University of Michigan, Ann Arbor. And that's been a game changer around the world, because prior to that, most men didn't know they had prostate cancer until it was advanced. And so they had some, terrible bone ache or pain, or something wasn't working, or a neurologic dysfunction. And then we'd find, oh yeah, you got cancer everywhere in the body. But the PSA really did change the landscape in terms of finding prostate cancer, curing prostate cancer with any method, surgery, radiation, freezing, heating, seeding, whatever you want to talk about. Big change. Gleason score is different. So for example, yesterday I did, biopsies. And what I did is I take tiny little pieces, and of course through the perineum, and send them to a pathologist. Now he looks under the microscope, and his job is to tell me how aggressive is that cancer. And initially the score went from 1 to 10. Now we usually say everything from 1 to 6 is bottled into a 6. But his job is to say, this is a Gleason score of. And the higher the number and the closer it gets to 10, the more aggressive prostate cancer is. And there are different ways to get the numbers. So Gleason score, what you typically do as a pathologist, you look under the microscope and you say, okay, I'm seeing a cancer in this little snippet. The predominant cancer I'm seeing in this little snippet, I'm going to grade it on a scale of 1 to 5. And it looks like a 3. So you get a 3. Okay, that's number one. Then he says, but there's another type of cancer in this little snippet that looks a little more aggressive. I'm going to give it a 4. And that becomes a 4. So you say it's 3 plus 4 equals 7. And that's how you derive a 7. Now just think about it. If the doctor said, oh, the most common cancer I see is a 4, and the second one I see is a 3, then it's 4 plus 3 equals 7. So with a 7, you can get it 2 ways, similar to a 9. It'd be 4 plus 5 equals 9, or 5 plus 4 equals 9. 10 is where you look and you say, oh, that's the most aggressive one I know of. On a scale of 1 to 5, I'm giving it a 5. And the other one I see is a 5 too, so it's 5 plus 5 equals 10. That's the more aggressive thing. So that's what Gleason score is. I personally like to also know in my little snippets how much cancer is in it. Is it 5%? Is it 1%? Is it 20%? Is it 80%? That's really important too, because it tells me about volume. And then there are other things like different architecture. For example, you may read or hear about, in addition to the Gleason score, it might be, I also see a cribiform pattern that behaves pretty aggressively, or I see intraductal that behaves really aggressively. Those are important things, and that's what I ask of my pathologists, and as do other doctors around the nation, from top pathologists. An interesting side note on that is that as I mentioned, you have normal prostate cells making PSA, and then it starts growing uncontrollably. And so it starts making more PSA, and your PSA goes from 2 to 3 to 4 to 5. But cancers of the prostate are interesting from the standpoint of they mutate like other cancers, but they never mutate down. So, for example, a Gleason 6 never becomes a 5, a 7 never becomes a 6. A Gleason 6 becomes a 7, 7, 8, 8, and 9. What happens is something of a paradoxical thing, and that is that as the Gleason score gets higher, the prostate cell doesn't resemble the original prostate cell anymore. It's just becoming like something ugly, and it's not making much PSA. And that's something that's really important. And I tell you this because, a lot of guys, they are diagnosed having prostate cancer. And, if it's a low grade, low volume, I follow them in what's called active surveillance. And what I fully expect is the PSA to rise over time, but slowly, okay? And that lets me know, yeah, we're safe if prostate cancer is growing slowly. It's actually when it starts going down that it gets my attention, because I know the cancer is now mutating to become something that's more aggressive and may not make much PSA at all. And the reason why that's so important these days is, there's a lot of other non-traditional treatments for prostate cancer, of which I'm not opposed to, as long as they're being done in conjunction with curative treatments. For example, there's ivermectin, there's fenbendazole, there's mebendazole, and I'm not opposed to them. They don't have any side effects, and they do have anti-prostate cancer effects. But I've also seen many men who do those things or just change their diets entirely, and they say, "Oh, everything's fine. My PSA was, 8, but it's now down to 4 or 5." It might not be because of the diet or the ivermectin. It may be that the cancer is just doing its natural thing and growing and mutating and becoming ugly and not making much PSA at all. So you got to be careful of that as well. And I think we're out of time, unless this gentleman had a question.
Did you say that if you do the biopsy through the perineum, once you do it, I have a high score. I'm waiting for a biopsy, but did you say the chance of it spreading is greater after the biopsy?
Not with the perineal biopsy. So with perineal biopsies, as I was saying, when you go through the perineum, the other diagram, there's never been a case report, of a patient has that kind of biopsy and it's spread. That would be more consistent with patients who have the biopsies done through the rectum. But it's a small number. Okay, well, thank you all for coming.
Simple question.
Yeah.
I need to set up an appointment.
Oh, we got people for that. Thank you all. Have a great day.